Welcome to This Explainer. I'm your resident host, and today I want you to go ahead and put on your internal medicine hats because we're diving into a really crucial topic for the wards. We are unpacking exactly why the first relapse is now the absolute most consequential decision point in a multiple myeloma patient's journey. It's a moving target for sure, so let's dive into it together.
Here is our roadmap for today. We're going to start off with the case hook, followed by step 1, which is biochemical versus clinical relapse. Then we'll hit step 2, prior exposure. Step 3, the whole patient. Step 4, new toxicities. And finally, we'll wrap up with the final decision.
All right, let's jump right into section 1, the case hook.
Because, on the wards, myeloma always starts with a patient. We don't just treat lab values, right? So let's look at the clinical picture here. We've got a 68-year-old man. He was diagnosed with multiple myeloma 2 years ago, IgK-kappa, ISS stage 2, standard risk cytogenetics. He went through a really robust induction with Dara-VRd, had his autologous stem cell transplant, and he's been cruising on lenalidomide maintenance ever since. But about 6 weeks ago, his light chains started creeping up. And last week, a brand new lytic lesion showed up on his spine. Here is the uncomfortable truth I really want you to sit with today. This patient has relapsed. And what we choose to do right in this exact moment matters way more than his frontline therapy.
You might be wondering, why does it matter more now? Well, this brilliantly illustrates the paradigm shift we're currently facing. 10 years ago, this was a simple drug swap. Relapse literally just meant you changed the drug class, started over, and hoped for the best. But today, the landscape has completely exploded. We have this massive arsenal at our fingertips. But the paradox here is that having more options actually makes the decision significantly harder. It's like a giant puzzle. If you use your absolute best weapon on a target that doesn't necessarily need it right now, you burn a vital bridge for the future. Treatment sequencing is everything. If you get it right, you can buy the patient years of high-quality life.
Moving on to step 1, biochemical versus clinical relapse. Before you even think about touching that prescription pad, you need to ask, what kind of relapse is this? Notice how the International Myeloma Working Group draws a really strict line here. On one side, you've got an asymptomatic biochemical creep, maybe just a slowly rising M protein or light chain ratio with absolutely zero symptoms. Often, especially in a standard risk patient, you can just watch this closely. You don't necessarily have to jump the gun and pull the trigger on treatment right away. But on the other side, you have active clinical relapse. This means new CRAB features. We're talking hypercalcemia, renal impairment, anemia, or new bone lesions, just like our patient has. If someone shows up with a new plasmacytoma or acute kidney injury, immediate treatment is absolutely required. No question.
You also got to assess the speed of the disease. Are they what we call functional high risk? This happens when the paraprotein doubling time is super short, or maybe they have high-risk cytogenetics like deletion 17p, or they've relapsed really early, say within 12 to 18 months of starting their initial therapy. If they're progressing this fast, you don't mess around slowly working your way up a ladder of triplets. You skip the ladder entirely and reach for your most potent tool immediately. Now, our patient has a new bone lesion, which makes this a definitive clinical relapse, so treatment is 100% indicated here.
That brings us to step 2, prior exposure. Okay, now that we know we need to treat, this next part is arguably the single most important question that we as residents consistently underweight. What has this disease already seen? Let's trace our patient's journey, frontline induction, followed by a stem cell transplant, followed by lenalidomide maintenance, leading right up to this first relapse. Because lenalidomide maintenance is pretty much universal post-transplant nowadays, our patient is very likely lenalidomide refractory or at the very least lenalidomide exposed. And that single fact, it completely reshapes the modern treatment menu.
So the crucial takeaway is how this changes our options. The classic guideline move used to be swapping to a daratumumab triplet, maybe Dara combined with pomalidomide or carfilzomib. And honestly, for a lot of patients, that is still a fantastic guideline-supported choice. But the data has shifted remarkably. Let's look at the modern shift. Thanks to the CARTITUDE-4 trial, cilta-cel, which is a BCMA-directed CAR-T therapy, is now actually approved for use as early as first relapse in lenalidomide refractory patients. It showed superior progression-free survival compared to those standard triplets. So for a fit patient, CAR-T is now a genuine frontline consideration at first relapse. It's not just a fallback for later down the line anymore. And sitting right alongside that are the bispecific T-cell engagers, which are just yielding incredible response rates. The decision isn't just triplet A versus triplet B anymore. It's a whole new ballgame.
Step 3, the whole patient.
Guidelines give you the list of options, sure, but the actual human being sitting in front of you dictates which one truly fits. You have to ask about these specific patient factors.
Renal function might dictate dose adjustments. You absolutely must evaluate performance status, frailty, and pre-existing cytopenias. Why? Well, because advanced cellular therapies like CAR-T require bridging therapy and weeks of lead time just for the manufacturing process. A rapidly crashing or severely frail patient simply doesn't have that kind of time. Plus, you have to ask, what are the patient's personal goals? Some want the absolute maximum depth of response and are totally willing to endure intensive toxicity. Others prioritize quality of life and staying close to home. Neither choice is wrong, and an algorithm can't make that choice for you.
And there's another massive factor that those algorithms usually just ignore: access. We can sit here and talk about CAR-T and bispecifics all day long, but we have to acknowledge the real-world access limitations. These complex cellular therapies require specialized centers, robust insurance, and extensive support systems. This highlights a massive disparity in global medical education and care standards. We have got to ensure that access to global standards actually reaches the bedside at home, no matter where in the world that home happens to be.
Addressing this access limitation is a huge undertaking. But as highlighted by frameworks like StudyMedic, which, by the way, is currently running a live pilot with the Uganda Medical Association, clinical excellence isn't just about reading the latest NCCN guidelines. It's about ensuring continuous, accredited mentorship and actively upskilling local doctors. By providing structured mentor-led pathways, we can ensure that these incredibly complex, global standards of care are safely administered to patients locally. That reduces brain drain and elevates care worldwide. It's a great reminder that practicing good medicine requires a global perspective.
Okay, step 4. New toxicities. So, assuming your patient does have access to these advanced therapies, you need to know that the side effect profile has evolved dramatically. Notice the specific toxicities tied to each therapy here. With CAR-T, you're dealing with cytokine release syndrome, or CRS, and neurotoxicity known as ICANS. With bispecifics, there's a very real, often underestimated risk of severe infections from prolonged B-cell aplasia and hypogammaglobulinemia. These patients frequently require infection prophylaxis and IVIG. And then there are targets like GPRC5D with therapies like talquetamab. These bring entirely distinctive toxicities, like dysgeusia, dry mouth, and severe nail and skin changes. I mean, you simply won't find these in your old carfilzomib or pomalidomide handouts. We are literally asking every internal medicine resident to become fluent in a brand new toxicity language. For instance, understanding CRS is no longer just niche subspecialty knowledge. It is a core competency now. If your patient has a fever, a sudden drop in blood pressure, or hypoxia post-infusion, that isn't just a standard code. That should immediately trigger your CRS protocol and get you thinking about administering tocilizumab right away.
Finally, Section 6, the final decision.
All right, so after breaking down the disease biology, the prior exposures, the patient's fitness, their personal goals, global access, and all those new toxicities, let's bring it all back to our 68-year-old man. Here's a quick recap. He is lenalidomide refractory, he's got standard risk cytogenetics, he is 1 year post-transplant, meaning he is dealing with a clinical relapse. But most importantly, he is fit and he's highly motivated. In the modern era, for this specific profile, he is a prime candidate for CAR-T therapy right now at his first relapse. And hey, if that advanced cellular therapy is not accessible or appropriate for his specific life circumstances, then we look at a daratumumab-sparing triplet built entirely around what his myeloma hasn't even seen yet.
The point here isn't to just blindly memorize one single algorithm. It's to deeply understand the why behind the choices. Myeloma management isn't getting harder because we know less. It's getting harder because we finally have enough incredible tools that sequencing itself has become the absolute art of the medicine. You always have to ask what the disease has seen, how aggressively it's behaving, and what the patient can actually tolerate and access. So, knowing all this, how will you sequence your next patient? Thanks so much for joining me on this explainer. I really hope this helps you out on the wards. Catch you next time.